focused on pain management, neuro, and we've got one cardiac arrest station, which should look very familiar to what you guys did last week. Some definitions. It's important to recognize that a narcotic is not necessarily a drug. When we talk about the narcotic effects of carbon monoxide poisoning, we're not saying that carbon monoxide gets you high. It just means that it puts you into a stupor, makes you a ton of, changes your mental status. It's a chemical that has some sort of depressant effect on the central nervous system. So different things will have a narcotic effect. So just keep that in mind in the back of your head. When police officers talk about narcotics, they're talking about opiates. And an opiate is a very specific type of medication that we all carry. We all know what an opiate is. But it's two separate things. So when we talk about narcotics, we might be referring to opiates. We might be talking about our narcotic kit. But really, we could, the word narcotic can be thrown around willy-nilly for pretty much anything that has a central nervous system depressant effect. It literally comes from the Greek word for stupor. So, like I said, carbon monoxide has narcotic effects. That does not mean that, that it is a narcotic. So we have a couple different options. We have narcotics, we have opiates, which we all carry for pain management, and then we have NSAIDs, non-steroidal anti-inflammatory drugs. What are some examples of NSAIDs?
Ibuprofen.
Yeah, Advil, Aleve, Naproxen. So analgesia and sedation. Do we put pain management high on the chart of things that paramedics do? Depends.
Depends on the medic.
Like a life threat, then no. But if there's no life threat, then yeah, something's got to be priority.
Yeah, if I fell off a trampoline and I had my a compound fracture of my humerus, if the medic doesn't give me pain management, they're going to need pain management.
BLS.
Yeah. But if that patient's not breathing, that's what I'm going to be more concerned about.
Yeah, hands down. Distracting injuries need to get to distracting injuries when you have a more acute case. The high acuity things, the life threats gets managed first. But when it comes down to it, when the little old lady falls down, breaks her hip, and is in excruciating pain on the ground, like, don't be that douchebag that just wraps her up in a fucking sheet, throws her on a cot, and transports BLS to the hospital. Treat these people with the dignity and respect that they deserve. Most of our calls involve some degree of pain, or have some complaint of pain, and whether they're a frequent flyer or somebody at a bum on the street, somebody that, like, it's super easy to just like put people into this package of like they don't deserve my attention because they're beneath me for whatever reason. Like, we're not gatekeepers. We need to hold the door open for everybody to the healthcare system, allow them in, and treat them with the dignity and respect they deserve, and give them pain management. For God's sake, there's no reason to take someone to the hospital.
Yeah, but what do you do in the case that you do have, like, everyone has that frequent flyer that calls once or twice a week, right?
Sure,
And they're looking for something, and you know they are, right?
Yep.
Almost like feeding a stray cat. If you keep giving them the pain meds, they're going to keep abusing the 911 system. So how do you handle that?
That is a fine needle to thread. You need to look at the case, work with your medical director, and figure out if this person's drug seeking or if they're legitimately ill. I've personally had people who have like pancreatitis, which is extraordinarily painful and oftentimes fatal. But this individual called probably once or twice a week to go to the hospital for pain management for whatever reason. I don't know why they weren't getting the pain management at home or if it was just getting exacerbated. But this is a legitimate painful illness, and the person's calling frequently, and they got narcotics every single time. They got controlled substances almost every single time. So you have somebody who's very acutely ill with an actual medical complaint, they'll get it. But you have this person who's just like clearly drug seeking, not putting the work in, and doesn't necessarily have an underlying medical condition that's relevant. Like, at that point, maybe you work with it and say, I'm not gonna write this in. I'm not gonna get this person pain management. Because you will have those patients. You will certainly have people who fake seizures to get a drug, or fake a medical complaint to get a drug. It's a thing. I tend to not withhold pain management from somebody who's clearly deserving of it. What are some objective signs and symptoms of pain that we can look at to say, like, all right, this person's legit?
Increased heart rate, increased blood pressure, things like that.
Yeah, sympathetic nervous system response, increased heart rate, increased blood pressure, guarding. You can look with some people when they're in severe pain, they're like full out diaphoretic, they look like crap. Like, you can use your objective.
I'm not talking about like the random person like that you might think might be faking. I'm talking about like the person who calls twice a week, every week, honestly, like.
Yeah, John down at the corner that you pick up every week and already has their bags packed and they're ready to go.
Yeah.
Like, again, this falls with, use your best clinical judgment, and if you don't believe that they're in the amount of pain that they're reporting, you're not obligated to treat them with controlled substances. You know, you can start off with BLS, keep them comfortable, happy, healthy, safe, and warm, get them on the cot, get them in a position of comfort, transport to the hospital. If they're drug seeking, you're not obligated, but you know, don't just be that salty old medic that's like, oh, they call twice a week. You know, the pancreas isn't really that painful, or you know, that endometriosis really isn't that bad. Like,
No, yeah, if they have an actual medical condition, that's different.
Yeah. Yeah, no, I get what you're saying. There's definitely people out there that like, I'm not gonna crack the box for it, but even those people, even those frequent flyers, they all get sick eventually too, right?
Yeah.
Especially our frequent flyers, because they probably don't have the best health care outside of the emergency room. The emergency room is probably the only place they'll see a doctor in their lives. And the ER is going to say, they're going to discharge them and say, go follow up with your primary. Like, their primary is the ER. So,
Yeah.
you know, they might not really get a lot of really good medical care outside of that. So it just falls into use your best judgment. Use your best judgment without being salty and trying to be accommodating to the patients.
Yeah.
But it's a narrow needle to try to thread when you're balancing that. So what are our options for pain management? What drugs do we carry? What do we have in our kits? What's that? We have fentanyl? Fentanyl, morphine, ketamine. Ketamine? Who works for an agency that carries ketamine? Who here has worked with a medic that's used ketamine? Okay. Pretty successful? 10 out of 10 would recommend. Do you carry fentanyl? Or, I'm sorry, not fentanyl. Ketamine?
Ketamine in the city? Yeah.
Yeah. Okay. So you have to dilute it with all the concentrations you guys get?
Yep.
One-on-one lines.
We do IV Tylenol, and I feel like I really like that.
IV Tylenol?
Mhm.
Yeah, I don't have that yet, but it's on my list of my to-do list. So we got morphine, fentanyl, ketamine. Those are the big three. Does anybody work for a place that uses nitrous? Nitrox, laughing gas?
Can't believe it's back.
I do. Oh, it's so good. It is so good. Instant gratification. Arnold's got it. Briggs has it. What's that?
I was
Right?
just thinking
Australia?
that, literally just gonna say, why don't we use that?
There was something, I think it had like, it caused cancer in a lab rat somewhere in California, and they decided it's not going to be good in the United States. They got rid of it. So they use it all over Europe and Australia. It's like super popular.
Culturally different, Europe and Australia, if I can. We had EMTs and paramedics overdosing on
The green whistle?
the green whistle, right? Because it's self-limiting.
Yep.
You hold the mask, and as soon as you go, wah, the mask falls away. There was a famous one in Westchester where a medic was into the nitrous, and he taped the mask to his face. And his partner came out. They got a job, and his partner came out, and he was in rigor already.
Oh, I never heard
Yeah,
that.
yeah, that's an old story. And there were a few of those, and the nitrous went away, and now it's back.
So when I was putting the nitrous package together at my other job, I researched as much as I could find if there were any fatalities associated with it. The only one I could find was in Russia. Some dude wore a gas mask and rigged up the tanks to the gas mask and fell asleep
Yeah.
when I was the editor.
Happy Richmond in White Plains.
Abbey Richmond, White Plains.
Mhm.
What does that cause, like hypoxia, because it replaces?
Yeah, just displaced the oxygen and
Yeah.
he wasn't getting any, and he had no way to remove the mask. So that's the cool thing about the nitrous. Like it's not strapped on. It's they just pop on the mask, and then when they start to get a stupor, they
Self-limiting.
Yeah, it's a perfect drug. I love it. So we got a lot of options. The nitrous is super expensive, so not a lot of places will carry it, but we do have a lot of other options. What opiates do we carry? What are the opiates?
Fentanyl?
Fentanyl and morphine, right? Which one is natural? Which one is synthetic? Fentanyl synthetic and morphine is natural. Which one do you give in milligrams? Okay. Do we give anything in micrograms?
Fentanyl.
Fentanyl. Why do we give fentanyl in micrograms?
You will die.
What's that?
You will die.
You will die if you get that in milligrams. Fentanyl is like 100 times stronger than morphine, so that's why we give it in micrograms versus milligrams. People patients will hear fentanyl and they get terrified about it because all they know in the news is that, oh my God, I smelled it once and passed out and almost died. Like we have a very, very controlled distribution of fentanyl, so we can try to calm people down and say, no, like I'm going to give you a very, very small dose. You'll still be conscious and you'll still be speaking to me. And we have reverse agents, right? What's our reverse agent? Fentanyl? Narcan.
One of the medics that I worked with, we went to a call for pain management, and he was quizzing me because he knows that I'm in medic school, and the woman's daughter was like, Howard, why don't you guys know how much fentanyl you're going to give her? He's like, no, I'm quizzing him.
I know exactly what we're gonna give actually. Couple downsides to morphine. Morphine fentanyl is a clean drug. Like pharmacologically, when we use fentanyl, it's largely good. It has all the effects that we want. It doesn't really have a lot of the negative effects. Morphine, however, although fentanyl has a bad reputation thanks to the news, morphine, however, is not a very clean drug. Morphine has some downsides to it. What are some downsides to morphine?
Not as long
Hypotension. What was the other one?
not as long lasting
It still lasts quite a while. You'll still get 20 minutes of pain management, but yeah, fentanyl's a little bit more concentrated, gives you a little bit better effects. But hypotension, so it'll drop your blood pressure potentially.
Heart rate too.
What's that?
Drop your heart rate.
It'll drop your heart rate as well. So it drops the cardiac workload altogether. So it drops your heart rate and blood pressure, which when you're dealing with acute coronary syndrome, when you're dealing with a heart attack, like those are good things to have because it decreases the workload of the heart, so the heart can just heal and not get as sick. But yeah, the dropping of blood pressure, especially in our trauma patients, not great. What's another downside? Histamine release. So morphine will cause a histamine release. So like something like 60% of patients will have nausea, vomiting because of the H1 activation, and a histamine release in general will cause you to have what? Gastric issues, certainly. H1 is gastric, H2 is skin. So what are you expecting? You have
Hives.
hives, yeah, itching and hives and a rash. It's not an allergic reaction. It's just an adverse reaction to the medication we're giving. It's an untoward effect. It's something you don't want to happen, but it's just what the drug does. It's a pharmacological effect. People could have an anaphylactic reaction to morphine. Don't get me wrong, like that's a thing, just like any other substance in the world. But most people get a rash and think they're allergic. So with morphine, you have to dig into a little bit more. Like, oh, what were your symptoms? Oh, it was a rash and I was itchy. Like, okay, that's the drug doing its thing. That's not you having anaphylaxis because you gave a drug. I'm not going to dig into it too much because I'll just say, okay, I'll give you fentanyl and like, we'll move on with our day. But just keep that in mind. With morphine, you will have a histamine release. Expect it. Expect nausea and vomiting. How do we counteract nausea and vomiting?
Zofran.
Zofran. So a lot of people get Zofran before they break out the morphine because you just expect it. So what drug class is morphine? It's an analgesic. What schedule is it? Schedule 2, so it's one of the highest tiers, but we can still use it. If it was a Schedule 1, we wouldn't even use it. When do we use it? What's our indication? Moderate to severe pain. And our dosage. I know the textbook gives 1, JDL gives 1, Guy, Paramedic Principles of Practice gives another, and then Pharmacology for the Paramedic Professional gives another, and then that book that Bernadette gave you guys is going to give you another. Roughly, what's a dose for the adult? 2 to 4 milligrams? Safe bets?
This has 2 to 5.
2 to 5? Also a safe bet? Any other takers? What's that? That's another acceptable dose. 0.1 milligram per kilogram is an acceptable dose for adult and pediatric patients, but generally speaking, you don't want to go over 10. At least not for that first dose. You can repeat dosages as necessary, but try not to go too high too quickly, literally and figuratively. So duration of action for the morphine is going to be 2 to 4 hours. Onset's going to be pretty much immediate when you get an IV. Fentanyl, what drug class is fentanyl? Another opiate analgesic, right? And what's the mechanism of action? Yeah, it's an opiate agonist, right? Yeah, the mu opiates, because there's different types of opiate receptors. And mu is the one that this works on. Adult dosage. What'd you say? 1 microgram per kilo. 1 mic per kilo. What are you going?
says 0.52 micrograms per kilo.
So somewhere in that range. It's going to be another weight-based drug. 1 is a good, safe, solid number. Again, when you're dealing with the elderly, you might want to scale that back a little bit. Start low and go slow, especially when it comes to opiates. Worst case scenario, we overdose with an opiate, what's going to happen? What takes a higher priority? What takes the highest priority? If we accidentally overdose somebody with an opiate,
Airway.
airway, right? Break out the positioning, OPA, head tilt, chin lift, ventilate it with a BVM, and then break out the narcan. If you have to. I've never heard of somebody accidentally overdosing somebody with an opiate, but if they have, renal disease or something like that, it's possible, especially if they're older. We all know our opiate antagonist. I had to put this in the slideshow just to say we talked about it, but if somebody overdoses on opiates, first step is control the airway, ventilate them. Remember, if we roll up to an overdose, we could ventilate them all day and they will stay alive. The Narcan is just a neat little trick we can do later on. Control the airway and everything else will fall in place. Moving right along. Not opiate analgesics. So those were our opiates. Now we walk into our other options. So nitrous oxide, ketamine, Toradol, Tylenol, all the famous ones. What does it sound like? Priority 2, 48-year-old male, severe lower back pain, kind of on the flank, says the pain is so bad that it hurts to walk, that he can't even walk. What else could it be? What are some things it could be?
Gallbladder.
Could be gallbladder. Gallbladder is usually females in their 40s, and that's usually pain right here. It could radiate into the back, certainly, but like the most common presentation is a female in her 40s, probably just had a fatty meal and severe pain right here, which might even hurt if you put pressure on it. But it's definitely something you throw in the bucket. So we got potential kidney stones, we got potential gallstones.
UTIs.
Yeah, could be an infection, just a generic urinary tract infection somewhere. Okay. Could be pancreatitis, could be sciatica,
Spinal injuries.
could be I was looking for AAA. Spinal injury, it's going to be more severe. It's usually going to be associated with some kind of fall or something like that. You got a cold fracture, really, really old, and just sat down on. This sounds like it's an acute onset, just medical. So it could be any number of things, right? We can kind of dial it down a little bit more, and as you guys get into your Med 1, Med 2 classes, you'll be able to narrow it down a little bit more so you can get that bucket of all the potential diagnoses and start weeding things out. It's probably not that, probably not that. For this class, the scenario is going to be the person's already been diagnosed with kidney stones and now they're just in severe pain. Our instinct when we have somebody who's in pain, especially when they're in such bad pain that we lay on the couch and they can't even move, our instinct is what? What's our pain management go-to?
Toradol.
What's our other pain management go-to? Morphine. Most medics will fall back into the opiates. They'll go with the morphine, they'll go with the fentanyl. Those drugs, specifically those drugs, will not work and they might make things worse because they're going to increase gastric motility and might increase the pain in the ureters. So A, it's not going to touch the pain, and B, it's potentially going to exacerbate the pain. So Toradol is going to be our go-to.
Could you use IV Tylenol for them?
I don't know if it would do what we're trying to accomplish. It'll affect your body's ability to the way it registers pain, but I don't think it'll have the same anti-inflammatory effects that the Toradol will. So Toradol is the gold standard for kidney stones right now. So what drug class is Toradol? Non-steroidal anti-inflammatory drug. Perfect. And what's our adult dosage?
15 up to 30.
15 up to 30. A clue here is most of our drugs are single patient, single use. So if you just looked at that and said, "Oh, looks like a single use vial," you're probably at least half right. Yeah. So 15 up to 30. Onset's about 10 minutes. Duration's gonna be about 2 hours. And again, it's a great drug for musculoskeletal pain and kidney stones. Those are the 2 home runs for this one.
So what about the, because I know contraindication is if kidneys aren't working well.
Renal
Kidney
failure.
stones, is that technically not considered renal insufficiency?
Yeah, because a kidney stone is literally just a deposit of salts inside the ureter that just got stuck.
Yeah.
So your kidneys are working fine, you're
Okay,
you're probably
so-
dehydrated, chronically dehydrated, or have terrible diet and eat a bunch of crap and just gums it up and creates a pebble. So your kidneys are fine. Nitrous oxide we just talked about, it's a 50-50 mixture of nitrous and oxygen. This device is a mixing valve, so we have a high pressure oxygen port that'll go onto your ambulance's oxygen tank. Runs at 50 psi, and the oxygen actually runs the unit. So if you run out of oxygen, the mixing valve here isn't going to work at all, and the nitrous will shut off. If the nitrous runs out, it'll just run pure oxygen, 100% O2, and Bell will start digging at you that the mixing valve isn't working because this is empty. So if you guys see this in, if you do a meet and assist with Arlington, they might be using this because it's a really good drug and you don't have to do as much paperwork with it. And just keep that in mind. You'll have to bring one of the medics along with you because these units are like $6,000 each, but they're pretty efficient. And like we said, you're not strapping the mask on. They literally hold it in their hands, and then when they get a little the narcotic effect from it, they just kind of nod off and drop the mask. And when they start having pain again, they'll perk up and breathe it in again. The onset's pretty quick. The onset's under a minute, and it wears off after about 2 minutes. A cool thing about this drug is it doesn't get metabolized by the body, so the drug you inhale is the same exact drug you're exhaling. So if you seal up the ambulance tight enough and turn off the vents, like you get a little nitrous too. If you really feel like it.
I've seen them use it during like labor.
Yeah, it's big in labor and delivery. If you're walking around like Vassar Hospital, you can still see the lines, the air lines for gas go through the entire building up to there. So it's category, I want to say it's category C for pregnancy. They don't want to see you give nitrous to pregnant females until it's time for them to go into labor, mostly because they don't know if it's going to have any effect on the developing baby, and nobody wants to take that responsibility. So they say don't use it in pregnant females until they're actually in labor. And once they're in labor, it's free range. Go for it. But really good drug, and it's a good temporizing measure, because if like you have somebody who fell and has a fractured hip or something like that, you just want to get them off the ground and into the ambulance and do the rest of your stuff over there, like especially like crappy weather. Like, put them on this, they take 2 or 3 breaths, pain's relieved, get them up onto the cot, into the ambulance, and then you can do the rest of your stuff. Ketamine? Who carries ketamine? So quite a few people have ketamine. I don't have this yet in my with my agency, but it's definitely one of the things that I want to get. What are some things we can use ketamine for? Excited delirium, extreme pain, RSI, it's an RSI drug. So we could do everything from give like a lower dose to give a little anxiolysis or a little pain management, or we can give a higher dose and just put them into a stupor. Some of the cool things about this drug is, unlike opiates, it's not going to drop your blood pressure and heart rate, so it'll actually increase your blood pressure and heart rate, which is like kind of an okay thing, especially if you're like in trauma and you're getting your shocking state, but not a great thing if you have a traumatic brain injury. If you have a traumatic brain injury, remember what happens when we have a traumatic brain injury, the pressure inside the head, thanks to the inflammatory process that Violante is telling us all about, pressure will get more and more. And if we give a drug that has like a sympathetic nervous system activation, it'll make things a little bit worse. So we want to stay away from that in traumatic brain injuries. Another thing to keep in mind is this drug has to be watered down. This is like the concentrated version. So whatever you're going to give, you have to dilute it in an equal amount of solution. So usually normal saline. Ketamine came up in the news quite a bit recently. What was the case where it was in the news out west? Paramedics gave what?
Giving ketamine at the direction of the police, and then that patient died.
Yeah, so paramedics were called out to, the whole case is bizarre. Some kid was walking home from work, a massage therapist, like 18, 19, 20 years old, from that ballpark. He's walking home, he's wearing a ski mask, 911's called because of the suspicious person. Law enforcement gets there and has an interaction with him. For one reason or another, there was an altercation, police put him in custody, and while he's in custody, paramedics were called to to put them to sleep basically with ketamine. And I guess that was like a standing order where their agency was. It was just like, oh, the cops want us to put them down, so we'll go put them down. So they went and hit them with the wrong dose of ketamine. They gave them an adult dose instead of a pediatric dose, and even that was wrong. I think it was almost double. And then that was the end of it. It was like no monitoring after that. If we're going to give somebody a controlled substance, what are some things we have to monitor? Heart rate, respirations, blood pressure, all the things, right? Anytime we give any medication, we're reevaluating in 3 to 5 minutes.
So they just like gave them ketamine and turned them over?
It sounds like they transported him to the hospital, but he coded at some point between where they gave him the ketamine and he got to the hospital. And I don't think they realized it right away. I don't know if they fell asleep and were waiting for a vent alarm to wake them up or something, but either way, it was not a good look. They all got arrested for manslaughter. Some of them saw time in jail. All of it very, very, very preventable with one simple tool, nasal cannula and tidal CO2 monitor, and then you can just watch what's going on right on the screen in front of you. And if there's ever a gap, you can press it right there. Opiates will do what to your respiratory drive? Drop it. Ketamine does not have that effect on your respiratory drive, but it will put you into a stupor, so you might lose, like the package insert says you won't lose airway reflexes, but that's based on giving the appropriate dose. If we overdose somebody and put them into a K-hole and have the position wrong, anybody can lose airway reflexes. Like sleep apnea is a thing. We still have airway reflexes while we're asleep. So I think that's what happened.
Even though they gave the wrong dose, would it have made a difference if they had monitored him?
I believe one report I read said that the gentleman had a heart attack after they gave the ketamine. So with the sympathetic nervous system activation we get from ketamine, it's possible that it increases heart rate and blood pressure so much that it strained his heart and gave him a heart attack. I don't know if that's actually what happened or if that was just the media sensationalizing what actually happened to this kid. If they monitored his airway and breathing and had him on the monitor, I think they would have kept his airway open and been able to manage his heart rate and blood pressure appropriately if they had done their job. If I give somebody a drug that I know is going to activate their sympathetic nervous system, and I see it getting out of control, and I see the blood pressure going through the roof and the heart rate going through the roof, how can we manage that? Do we have any drugs that could affect heart rate and cardiac output? Yeah. So if we had to, if we started seeing a dangerous rise in blood pressure and heart rate, we could certainly start doing some medication therapy, maybe a beta blocker, and bring some of that stuff down. So we have options, but they just completely neglect their duties as paramedics and healthcare providers and face the consequences. Unfortunately, someone lost their life because of it. But with any medication we give, keep monitoring the patient afterwards. With any controlled substance we give, end-tidal nasal cannula, watch the respirations. Like we talked about this before. We talked about this in airway. Nobody on Earth actually counts respirations because we're lazy and we just like, oh, it looks normal, like, that's fine. But put them on the end-tidal nasal, and it's no longer subjective. You're getting an actual objective number and a waveform, so you know exactly what's going on. Take the human nature out of it, get the laziness out of it, and just have the computer tell us what's going on. And if for some reason you don't have end-tidal nasal, actually sit there and count the respirations. For God's sake, it takes 30 seconds. It's not that hard. All right. The next drug is going to be Tylenol, IV Tylenol. You said that you guys carry this in New Windsor? Newburgh? Okay. What are some cases you guys have used this in? You said you like it, so where has it worked?
It's like pain that's like mild pain.
Okay, so like a musculoskeletal pain, like I think I pulled a muscle in my back or something like that.
I'm trying to remember who used it recently, and I can't remember what exactly for, but I remember spiking it, and I just can't remember what it was for.
I had a positive outcome regardless.
Yes, it works well.
Yeah, hospitals use it all the time. We just got it within the last few years. Not a lot of places carry it yet. I'm not entirely sure why, but we have IV Tylenol, we have PO Tylenol we use. What are some indications we could use Tylenol for? Pain, obviously. Is there anything else? Fever, right? Especially kids, we can give Tylenol to control fever in kids.
Oh, now I remember what it was for. No, it was both simultaneous pelvic pain and fever. She had like pelvic inflammatory disease, but they were thinking like maybe sepsis.
No comment.
Her fever was like 102.5. So we gave ibuprofen.
Okay, that's fair. I mean, it'll work. Yeah, it doesn't really do anything for inflammation, but it definitely affects your body's pain pathway, the way your body perceives pain. So
Yeah.
it'll work for that, and it'll reduce fever, which is fantastic. One thing to keep in mind with Tylenol is if you're called to a scene and someone's like been sick for a few days, or a kid has been sick for a few days, every fucking medicine we carry, or every medicine that they get over the counter, almost everything has Tylenol in it, and we just need to make sure we're not giving it within a 6-hour window. So if they've already gotten cough medicine, just make sure it doesn't have acetaminophen in that cough medicine. And almost every cough medicine has it. So there's a good chance we might not be able to give the IV Tylenol just because they've already gotten a dose and we don't want to, destroy their liver.
So you give ibuprofen then?
Yeah, that's like, as parents, that's what they tell you to do. Give one Tylenol, give one ibuprofen every 4 hours, and then there's some overlap. So when one is starting to wear off, the other one will come in and kick in. We don't carry ibuprofen, but that is certainly what you would want to do.
I think Town River has ibuprofen. We have ibuprofen.
Do you have ibuprofen?
Yeah,
Yeah.
this is ibuprofen too.
It was like Empress also had ibuprofen.
You guys are well ahead of me then. I didn't even realize it was in the protocols. Okay. Just PO?
Yeah, just,
Mhm.
very fast.
Okay. I didn't program that into this class because I didn't think that was even a thing. You learn something new every day. I'll have to look into that. But yes, in that case, you would just alternate every 3 hours. You would get one or the other. Because the duration of action for the Tylenol is about 4 to 6 hours. So we want to make sure it's out of our system before we give
That's
it.
what I'm asking, like, would that be, I don't know, like, is that protocol, like, if a kid had a fever, but we can't give acetaminophen because,
I didn't even realize it was in the protocol. So
so is that what we would do? Would we give-
that would be the reasonable thing to do.
News to me. It's in collaborative protocols.
Yeah,
I was
no
like,
idea.
yeah.
This is what happens when you're salty old fuck.
400,
That would probably be the only indication for the ibuprofen.
400 milligrams in 20 mLs PO.
PO? So it probably comes in one of these fancy little cups too?
Yes.
Yeah.
Alright, cool. Yeah, that's probably why they gave it to us. If they gave us the Tylenol, it makes sense that they would give us ibuprofen too, so that way we could be like, oh, we can still give you something, even though you just had a whole bunch of Tylenol. Alright, medications used for neurological conditions. What are our neurological conditions that we deal with here? It's pretty much universally seizures. What does a seizure look like? This is a long question. Okay, so what are some ways that seizures can present?
Stare it off and nothing.
Okay, so like an absent seizure or a non-tonic kind of seizure where it looks like you're daydreaming. So there's 2 different branches. You can have a seizure where you have a loss of consciousness, or a loss of awareness, and you can have a seizure where you still have some awareness. Like it could be isolated from extremity. It could be you could just look like you're daydreaming and you're shaken out of it. They're pretty bizarre, but most seizures are self-limiting. 90% of the time, a seizure is self-limiting. When we get involved is when it's not self-limiting. If we get called for a seizure and they're still seizing when we get there, it's probably been going on for 5+ minutes. Like that's usually the cue to start acting. If seizures lasting longer than 5 minutes, something is probably up and probably needs to be addressed. Or if there's 2 or more seizures where like maybe the seizure started and then stopped, but they never really became lucid and started talking to you, like that is also concerning. There's just recurrent episodes of seizures without a lucid interval. But our concerns here, what are our concerns with seizures? Airway. Through airway. We want to protect them from themselves, right? So if they're having a tonic-clonic seizure on the floor, we want to move stuff around so that they're not like, hitting their head on the table or, anything's going to fall on them, so protect the patient. We want to protect their airway. Another concern is that for some reason during the seizure process, there's a lot of drool. They hypersalivate, so you have to be able to have suction ready or put them on their side so they can drain, so they can breathe appropriately. What was the other thing?
They bite down on the tongue.
Yeah, they might bite down on their tongue and create an air obstruction from either a piece of tongue or just the blood. Again, that's another reason why you might want to try to get them on their side, position them in such a way that you can control their airway. But again, any seizure that lasts longer than 5 minutes is very concerning because you could have permanent neurological damage after that. And again, some seizures are more clear than others. Sometimes you just get that, that
I was very confused for a second.
So is oh, it is that.
sometimes with the seizure, you'll just get like a conjugate gaze where they're just like non-responsive and the eyes are up and to the right or up and to the left. Sometimes it's pretty clear. Fortunately, with YouTube, people film this all the time. You guys will see in Med 2 that some people will have like an aura, or they'll have a weird sight, or they'll sense a smell that's not there, and people will get tuned in with like, oh, this is what happens when I have a seizure. Maybe I should sit down.
I've had patients tell me I'm about to have a seizure.
Yeah, it's a thing. Like the electrical storm in their brain is starting to go off, and it's just hitting sensory areas, and they'll say, oh, this is not good. I'm gonna have a seizure.
Yeah, the weirdest one that I ever saw was this lady was like, I'm about to have a seizure, started cracking up laughing, and then like full blown seizing. And I was like, that was weird.
Yeah.
Then it's your turn to laugh.
She's like, oh shit.
Who's laughing now?
Yeah.
So the seizure broke. Notice the hypersalivation here. So have the suction ready. Fortunately, they're already on their sides. They're draining, but if they were laying on their back, this could be a pretty significant problem. So if that seizure started at home and we were called, we're probably still not even rolling out responding yet before the seizure ended. But if that was continuous, think about how much activity was going on there. If that was continuous for 5-10 minutes, like that's pretty significant. We're gonna blow through all their glucose reserves pretty quickly. So our medications to treat seizures, what do we have? Versed. What's Versed other name? Midazolam. And our other treatment option for seizures? Ketamine, if you want to just completely knock out all responses potentially. But our primary drugs are going to be the benzos. So we have Versed. What's that? Diazepam. What's diazepam's other name?
Isn't that Valium?
Valium.
And the other one is Ativan. Ativan isn't quite as good, but sometimes if there's a drug shortage, we'll still get Ativan. What drug class are all those? Benzodiazepines, right? So we got Ativan, lorazepam, diazepam. Cool, that's it. So we're gonna go into the lab. We have the same 3 groups. Does everybody remember what groups they were in? Anybody not remember what group they were in? You don't have a group? Oh, no, just for airway. What we